Okay. Do you guys hear me?
Yes, doctor.
Yes.
Yes,
Great.
doctor.
So I want to volunteer from our fellows. Or I will pick.
You please go ahead and pick according to availability, Dr. Yahya.
Dr. Ramona Salah, are you there?
Yes, Dr. Yahya. How are
Great.
you?
I'm very good. How about you?
Alhamdulillah.
Okay. So here is the case. Okay. And what I want you to do is I want you to go clinical. What exactly you'll do? And I will interrupt you. And if somebody want to ask a question, we'll raise hand, no talk, just raise hand, and Rula will take the question and will ask. They will ask you, or if they want comment, or they are practicing in a different way, and I will ask you why and so on. But we don't need theory, just go by practice. What exactly you do when you face such a case. Is that clear?
Yeah. Yes, clear.
Okay. And Dr. Arula, you take questions. Okay. Mute everybody. Take questions and you ask Mona or a comment or a change of practice or a different way of doing it or why or explanation, whatever needed online that you will ask by taking questions from people. Okay.
Okay, please. Yes.
Okay, so here is it. You have a 31 years old gravida 2 para 1, Dr. Ramona. She's pregnant with 25 weeks. She's in active labor, 7 centimeter dilatation, prompt for 21 hours, antenatal steroid, 1 dose 3 hours ago. And she has gestational diabetes on diet only. Antenatal ultrasound today, expected weight is 650 grams with a comment, no obvious malformation. So they informed you what you will do. The baby is not delivered yet.
Okay. Well, I want to know if the mother received antibiotics.
No, she did not receive antibiotics. She just came like a few hours ago. Let's say they gave her 1 dose.
Okay. Okay. Well, how far she is? She's in active labor.
She's in active. Let's say 7 centimeter right now.
So I would like to go and prepare the labor room for the baby.
You'd like what? Sorry, صوتك أعلى عشان حتى أسمع.
I would like to go and prepare the labor room to receive the baby.
Okay, so you want to go to the labor room to receive the baby. Okay.
Yeah.
Don't you want to do something else before that?
I want to counsel the mother.
You want to counsel the mother. So you have a few minutes, few hours. What you want to tell her?
Well, I will tell her that of course she's 25 weeks pregnant, and she has a risk factor having premature rupture of membrane for 21 hours, and she had received only 1 dose of steroid. And I will prepare her that after delivery, her baby will be handled by pediatrician, and he will require resuscitation, might require intubation and ventilation, and the baby will be admitted to the NICU. And I will just highlight on some of the expected problems that we may face with such extreme premature baby.
Okay. Go on.
Yeah.
So can I ask you a question, or are you finished?
Yeah, sure. You can.
Okay.
Go ahead.
So don't you think, like, if you are the mother, what is the common question you ask?
The survival.
Yeah. Did you tell her the survival?
Yeah. Well, of course, she's.
No, did
she's
you
already
or you did not? Wait.
No, not yet.
You did. Okay.
No.
So you have to tell her, right?
Yes.
Okay.
So we'll tell her that the baby is 25 weeks, so baby has 60 to 70% survival rate. Hello.
Mute yourself, please. يا دكتور محمد شحاتة. ترى رولا ميوت محمد.
Okay.
هتصحى ولا تصحى؟ هي فيها
لا خدي كلية كده
Yeah, Doctor, remove him, Dr. Arula, remove him from the group.
خدي يا حبيبي.
أنا مش عاوزة.
Okay, Dr. Amuna, continue. Dr. Amuna. Dr. Amuna. Well, you mute, I think you muted everybody, Rola.
لا I muted one by one but I think yeah
Okay.
I should
Yes,
come
yeah, I
here.
was muted also, yes. Okay.
Okay, so Dr. Amuna, okay, she asked you about the survival, and what's your survival will be?
60 to 70%.
Okay, so you expect that 60, 70%. So that's what one of the expected question. What other expected question, if you are the mother, will ask?
Disability.
Sorry?
Disability. Percentage of disability.
Oh, yes.
Survive with disability.
Complications. The expected complications.
Yes.
If the child make it.
Yes. If the child
Okay.
makes it, yeah, expected complications, yeah.
Okay. What other questions you are the mother want to ask?
How long the baby will stay in the NICU?
Yes. When the baby will go home. Yeah.
Yes.
So when the baby will go home, you think.
Yeah.
So if the baby survive, okay.
Yeah.
So what,
Yeah.
the expected baby to go home in 25 weeks.
Yeah, baby will go home if at 35 weeks baby has baby is already in room air on full feed,
25
tolerating.
or 35, you mean?
35 weeks corrected age.
35. So in 10 weeks,
And-
expect the
yes.
baby can go minimum 10 weeks.
Yes.
Right?
If at that time baby is in room air and he's on full feed by mother or by bottle.
Okay. So your baby delivered.
Mhm.
Your baby delivered, and you are there. You didn't tell us you will prepare. You didn't tell us that you have to prepare yourself. You have to prepare your staff, your nurse, your
Yes.
intubation, your respiratory support, your lines, your medications. What's the medication you will start? What's you about the incubator, the room temperature? You need all to do that, right? So
Yeah.
let's give you time. The baby is not delivered yet. So what exactly you want to do?
I want to make sure the room temperature in the labor room is 24 to 26 degrees.
24 to 26, you sure?
Yep.
No, it is, I in my practice, I do 27.
Yeah. Okay. Well, you know our practice, Dr. Yahya, even we cannot reach sometimes to 24 degrees.
Well, you will not have a good survival rate then.
Yeah,
One of
exactly.
the principle of survival rate, Doctora, for, if it's 27 and above, it's 28 and above, that it won't be a big problem. But if you want to work with 22 and 23 and 24, these
Yeah.
tiny details are vitals for survival. So
Yes.
the room temperature, the lowest the room temperature, the more the death rate, the more,
Yes.
decreasing your survival rate. So the room temperature should be 27.
Yeah.
Okay. What else?
Then I'll make sure the resuscitator is working. It's on. The suction is working. Oxygen source is working. And
Working,
the
or you want to
CP
do
is
pre-warm?
Yes, I will put it on and keep it warm.
That's not enough.
Uh,
That is not enough. You need to make sure that the temperature of the incubator, what is the first temperature
Yeah,
of
I will-
incubator?
Yeah, I will increase the temperature of the incubator, and the resuscitator I will receive the baby also. It should be
Well,
pre-warm.
basically, you need to open the warmer if you're doing the resuscitator. But let's say if you
Yeah.
have a good transport incubator, what will be the temperature of incubator you want to set?
36.
Yeah, so somewhere between 34 to 36. Yeah, I agree with
Yeah.
that. Okay, and you open the warmer and you have
Yes.
mattresses. You want to, make a dry
I will,
towels, at least 3. You need
Yeah,
a plastic
bag.
right?
Yes. Yeah. TPs. ET tube ready in case baby needs intubation.
Okay,
I will prepare IV fluid, dextrose 10%, or dextrose 5%, and caffeine.
okay.
Of course, the NICU staff will be called. 2 NICU staff at least will be
No,
called.
in your practice, don't tell me theory.
In my practice, we call 2 NICU staff if they are available.
Okay.
A minimum of one, but optimally we call 2 staff at least.
Okay, so now let's assume your ideal situation and you are 2 physicians and 2 nurses. So how you
Yes.
assign the roles for them?
The roles, one of the I will take the airway and like ventilation, and one of the staff, the senior most, will take the IV line.
Okay.
And the other colleague will take care of circulation, and one
Okay.
staff will prepare the medications for us.
Medication and documentation. You want somebody to
And
document,
documentation.
right?
Yes.
Okay. And in addition to your airway, you will be the event organizer. You will give the orders, right?
Yes.
Okay.
So
So I think now you're ready to take the baby. Okay.
yeah. Yes.
So let's assume that the room temperature is ideal, 27, and please work on that if you want to improve your survival rate. Your room temperature is 27, okay? Now imagine, remember that this baby only received 1 dose of steroid and it's only like few hours before. And there is leaking somewhat, and the baby is born. The baby is crying with good tone. Okay, so the baby born in a good situation. Your temperature is 27. You have 2 staff. You have 1 other colleagues. You have the resuscitator open. You have all the tools, and the baby born. You can hear the crying, and there is a good flexions. There is a good tone. What you will do?
I will give positive pressure. Of course, I will keep the baby in the plastic bag. We'll give positive pressure ventilation. I will ask the staff who's assigned to insert a peripheral IV line.
Before that, what do you want to do?
Before that?
Yeah.
We'll,
First thing you should do.
We'll dry the baby, place a cap, put
the baby is not given to you yet. A baby born, you hear crying.
Okay, I will ask the obstetrician to hold the cord clamping, to delay the cord clamping.
So you need to do delay cord clamping. Remember, this is another pillar. The first pillar was?
The temperature.
The second pillar is?
Yeah, delayed cord clamping.
Delay cord clamping. The third pillar is? Antenatal steroid.
Antenatal steroid, yes.
So antenatal steroid, delay cord clamping, room temperature are your pillars. What else? Magnesium sulfate to protect the brain.
Yes, antenatal.
Okay.
Yeah.
These pillars of resuscitation are vital. There are other pillars we'll talk about. So remember these, never forget them.
Yes.
Okay. So the baby born and you want to do delay cord clamping for how long?
At least 2 minutes.
So if possible, you're doing 2 minutes. And if you, but if your room temperature is not ideal, you won't able to do 2 minutes because you get dryness, hypothermia.
Yeah.
Right?
Yeah.
So that's important of changing the room temperature for delay cord, for ideal delay cord clamping, right? Okay, now you are fortunate to do 2 minutes delay cord clamping. The nurse, the obstetrician cut the cord and gave the baby to you.
Yep. So we'll take the baby, place the head cap, place the polyethylene bag.
Okay.
And start ask the staff, the NICU staff, to insert the peripheral IV line.
So no, before what you need to do first?
And the baby is crying already with good tone, so I will start positive pressure ventilation with a new pump.
Okay, positive pressure. You sure?
Yeah, we'll give a peep to the baby.
Oh, you will give a peep?
Yes.
Mona.
He's breathing already. The baby is breathing.
He's breathing already. You will give peep.
Yeah. Yes. Well, I will not give only oxygen initially. I would like to give.
You will give peep.
Yeah.
Not CPAP.
CPAP, I mean. But which is
so
what is available? What we have is not CPAP, so I will give.
So you'll give CPAP. Okay.
Yes.
What type of CPAP you want to give ideally?
6 to 8.
No. What is the type, not the level?
CPAP, continuous CPAP.
You want to do Constant CPAP or variable flow CPAP or bubble CPAP?
Well, okay. I will give constant CPAP.
You will give constant flow CPAP. Why?
Yeah.
I
Because
disagree. I disagree with you, by the way.
oh, okay.
Okay, why you want to do constant flow CPAP? Not variable flow CPAP.
I will. Baby is breathing with good effort, so I will give only constant flow CPAP.
Yeah, but oh, so is that the reason baby breathing? Then we'll give constant flow CPAP. But if the baby is not breathing, we'll give variable flow CPAP. Is that what you're saying?
Yeah.
Okay, now that's wrong. So what is the
Okay.
difference between variable and constant flow CPAP? And bubble CPAP. You have 3 types of CPAP, right?
Yeah.
So do you want other fellows to help you?
Yeah, sure.
Let's go with Dr. Hiam. Do you hear me? Dr. Hiam, do you hear me?
You have a volunteer, Dr. Ahmed Dana is saying I can
Dr.
answer.
Ahmed Dana, please go ahead. Well, he's not a fellow, but go ahead.
السلام عليكم دكتور حياك الله.
Assalamu rahmatullah. So tell them what's the difference between constant flow CPAP, variable flow CPAP, and bubble CPAP, and why you're using which one?
I'm going to use the variable flow CPAP. Why? Because when the baby is breathing, of course, he's inspiring the air, so the pressure is going down with that at that time because he's using negative pressure. So the variable flow, the machine is trying to achieve a pressure, so will increase it will increase the flow to achieve that pressure. And if the baby is expiring, so he's there is too much. The air is going out, so the flow is keeping constant. This can cause, of course, increase in the pressure and can cause pneumothorax in some cases. So yeah, I will go
Ahmed,
for
you're
variable.
correct. You're correct. But let's ask Mona. Did you understand what Ahmed trying to say, or no?
Yeah.
Okay, so what Ahmed is trying to say, he will use variable flow CPAP. And
Yeah.
variable flow CPAP has a nose generator. And the nose generator will make sure that the flow is variable while the pressure is constant. And that by how do that? Using fluidic flip principles. So when the baby breathes out, the machine will not support or support less. When the baby breathes in, the machine will support. While in constant flow CPAP, the pressure is generated not at the nose generator, but at the expiratory valve in the delivery machine. So the baby will breathe against the column of the pressure from the nose to the expiratory valve. So the baby will breathe in comfortable, but breathe out very tired. And that is one of the reasons you fail CPAP, because you will exhaust the baby. So basically, you want the baby to be comfortable. When he breathes in, need more flow. When he breathes out, will take less flow. Where is the flow will go? Will go out through the nose generator using fluidic flip principle.
Yeah.
While if using constant flow CPAP, the flow is constant and the pressure will go up and down. So it will not be a constant pressure. So when the baby breathes out, the pressure will go very high against the baby. So the baby will fight the machine. The constant flow CPAP is good with ram cannula for transport because you don't have a self-compressed battery-enabled variable flow CPAP. So during transport and when you expect extubate a baby, you use a constant flow CPAP. What about the bubble CPAP? The bubble CPAP is generating the pressure by handmade method, by analog way. So it need lots of labor to generate because it's not automatic. So first, you don't need to give PPV, you don't need to give PEEP, but you need to give variable flow CPAP. Okay? Okay, Dr. Ramana?
Okay. Okay.
So what the pressure that you will use? How many centimeter?
I will give the CPAP 6 to 8.
You will give 6 to 8. So if I ask you to select 6 or 8, which one and why?
8.
You select 8. Why?
Yes. It's a small baby,
Okay,
so baby will tolerate a higher CPAP.
why?
To prevent the alveolar collapse.
Yeah, but why 6 will prevent alveolar collapse and 8 will prevent alveolar collapse? But why you selected 8?
It will give better support to the baby.
It will give better support to the baby, but what about the complications? What about the side effect of 8?
And
Let's
small
assume
babies
you
are not.
have a term baby with respiratory distress and at 25 weeks with respiratory distress, and you decide to give CPAP. Which level you select for which and why?
For big baby, I will select a lower CPAP
Why?
because baby will is going to fight more and the chance of pneumothorax is more.
That's one. Second,
Liam has
Uh,
do you want help?
and
Liam
yeah,
has
sure. If anybody want to
Yeah,
help,
Victoria.
they are welcome to do.
Yeah, actually, I'm thinking in extreme preterm, it's better to go for high PEEP and then reduce it gradually. So
Why?
we ensure the alveoli recruitment
Okay.
because
But
there is
why
no Cervanta. It
you
is
do
a
that
balloon.
term?
You remember the balloon? This
Okay,
one,
so why you
balloon
want the
theory,
higher
your balloon
without
theory?
yet?
Yeah, because if we are give a higher pressure, like you are inflating a new balloon, so you need high pressure initially to inflate the balloon because it's not used yet, and because you
Oh.
expect Cervanta deficiency, so the
So let
surface
me-
tension will be less. So the less the
Yes.
pressure, the more chance to collapse.
Okay, so let me help you.
Correct?
You're close, but you don't
Okay.
reach the point. Now,
Can I answer?
when we measure compliance and resistance, the
Yeah.
system looks for the
Hyperthermia may cause pneumothorax.
no, sir, it will not cause pneumothorax. CPAP has nothing to do with pneumothorax. PEEP and CPAP has nothing to do. Even if you go 15, they will not cause pneumothorax. It has nothing to do with pneumothorax. So let me go. So if you have a compliance and resistance, when the system like a CPAP or a ventilator measuring the compliance and CPAP, these systems are assume that these compliance and resistance is from the lung. Okay, but what is the difference between a term and preterm baby other than the lung?
The chest wall.
The chest wall is pliable, right? The chest
Yeah.
wall is very soft in a preterm
Yeah.
baby, while in term baby,
It's more compliant in preterm baby.
in term baby is a little bit stiff. So
Stiffer, yeah.
resistance and the compliance will be less in term baby, and the resistance will be very high. Okay,
Yeah.
so if you start with high CPAP, you can cause pneumothorax.
Yeah.
But in term baby, if you go up, you start with up, the risk of pneumothorax is less because the chest is very pliable. You need stenting.
Yeah. More compliant chest wall.
Okay, so in a preterm baby, I will go with higher level and go down. And in
Yeah.
a term baby, I will go with lower level. If I need, I go up. And that's what we call it dynamic CPAP. Okay,
Yeah.
so anyhow, you started with CPAP of 8. Okay,
Yeah.
what is your FIA2?
If I do, I will start with 40%,
You will
and I
start
will
with,
titrate. Yeah.
why?
I will start with 40% and I will titrate it down to maintain a saturation of at
Okay,
least 9.
I will start with 30%, but you will start with 40, that's okay. And then you titrate down. Okay, so you started CPAP, variable flow CPAP. You're very fortunate. You have in the labor room variable flow CPAP. You started
Yeah.
CPAP. You started odd CPAP, 6 centimeter of water, and you fix that. You cover the head, and now it's 2 minutes of life. Your heart rate is 110, and your saturation is 70%. Okay,
Yeah.
what you will do? And you already cover the baby with plastic bag.
Yeah. We'll insert IV line.
You will try, so you'll ask somebody to insert a peripheral IV, right?
Yes. Yeah.
Okay, how many trials you will give them?
2 trials.
2 trials, and if they fail?
If they fail, then we can go for, I can wait to transfer the baby to an ICU
So you
and
transfer the
insert the
baby to
line
an
there.
ICU. Okay.
Yeah, I will transfer the baby soon, or we will, if needed, then I will go for central line insertion, for UVC insertion in the labor room if required. If baby requires
What-
resuscitation.
What type of UVC insertion in labor room you do?
Well, because in labor room it will not be ideally sterile. So I
Okay.
would prefer to go to an ICU and do the IV line
No,
insertion.
but if you decide to do it in the labor room, what type of UVC you will do?
I didn't get the question.
Well, you decide to do,
Hey,
maybe it's very urgent, you cannot move to an ICU, you decide to put UVC. What
Yes.
type of UVC will you put?
feeding tube.
No,
No,
you have
well,
a
I will have a UVC,
vascular catheter. You don't need a feeding
but it
tube.
will be like emergency insertion.
Yeah, what type of it? What type of UVC you have? What type of insertion?
Can you talk about your practice, Muna?
I will calculate according to the estimated baby weight and will insert according to the calculation.
Yeah, so you will insert normal high level vascular catheter
Yes.
in labor room.
No, low level.
Well, it will not be high level, it will be low level.
So you will insert low level, Muna. That's the type of
Yeah.
insertion.
Yes.
Okay, so if you don't get IV, you will insert a low level vascular catheter, UVC. Okay.
Yeah.
So you are very lucky, and the nurse got the IV, peripheral IV, and now you're on CPAP of +6. Your FiO2 is 35%, and your saturation is 75, and you are at age of 4 minutes.
Yeah.
Okay, go ahead.
So we will start the IV fluid at
What
80
type of
ml per
IV
kg
fluid?
per day. Dextrose
Sorry?
5%. Dextrose 5%.
Dextrose 5%.
Yeah.
5%.
Yes.
You sure?
Yeah.
Oh, okay, why 5%?
The baby is prone to hyperglycemia also, so I would like to start with 5% and not 10%.
Why? How you calculate it?
No,
How
I will
you calculate
calculate
5%?
at 80 ml per kg per day.
Okay, but how you calculate sugar? On which base?
No, the GIR, according to GIR, but I will not give.
Okay, so what type of GIR you want to give?
I will give him at least 4 to 5 GIR.
4 to 5. I will give way higher than that, Dr. Ramana.
Oh, okay. Well, that's
Way,
in the labor
way
room.
higher than that. So what is
Okay.
the normal glucose intake?
I'm not sure I'm getting the question.
So if you give 4 to 5, what will happen to the body? If you yourself getting 4 to 5 milligram per kg per minute of sugar
Okay.
over 24 hours, what will happen to your body? Do you want help?
Yeah.
Somebody can help Mona. What is the GIR and what are the effect of different GIR? So if Mona want to give 4 to 6, I would say 6 to 8, but
Yes,
Ahmed want
doctor.
to give 9 to 11, and Hiyam want to give 11 to 12 milligram per kg per minute. Can you tell me what is the difference on the
Doctor,
baby?
can I help?
Sundus, please go on.
No, we'll speak about only the fellows, Dr. Sundus.
Okay, sorry.
Yamin? Yamin? Dr. Yamin? Anud? Mahmoud? Nobody? Here, Arula. Dr. Arula.
If we increase the GIR means either we
No.
are increasing the percentage of dextrose or increasing the rate of the dextrose which is flowing.
Yeah, but why?
Our
Like
D10 roughly will be 6.
No. She's confused. She want to give 4 to 5 milligram per kg per minute.
Or
If I
let's say 5,
understand her very well.
but not
So
4, maybe 5.
what's the rate you will give and why, Dr. Hiyam?
This extreme preterm will start with 80 ml per kg per day. So
No, that's the
rough
fluid. We're talking about the sugar intake, Dr. Hiam.
I will start 6.
You'll start with
Almost
6.
D10.
Why?
The target is to optimize random blood sugar for the baby. I think 6
Sure?
as a
You
start,
sure the
and then I can. No, I'm not sure. I will check.
From where you get the target?
I will start D10, and I will check blood sugar.
Oh, so you'll do a
So
trial.
stabilizing the baby. Yeah.
Okay, but what is there is a better way of done trial and error?
Tell me. I don't
I
know.
tell you, we depend on
Evidence.
the placental infusion rate, Dr. Hiam. Okay? We depend on the glucose rate from the placenta. So we target the same rate.
Mhm.
And thus we will prevent the fasting and we prevent sugar. So what you want is the sugar to hit the baby in a placental glucose rate before 20 minutes. Otherwise, the baby will start fasting. And you will
Which is how much?
that's why I want to ask you. That's why
I don't know.
I was questioning Muna, why she wants high. That's what I want to know from you. What is the protein infusion rate? What is the glucose infusion rate? And what is the fat infusion rate from the placenta?
Yeah, we
We
need to
have to
read about
search
it.
that.
Yeah,
Sorry for that. We have to review and come back to you.
we have to read
Okay.
about this. Yeah.
So the best infusion rate to keep the placenta, and if you go and read about monitoring nutrition of the baby, you need to keep the placenta because actually we don't know what is hypoglycemia and what is hyperglycemia. We measure it directly from 2 ways. When the baby starts to decompensate, which means if you decrease, you get metabolic acidosis. If you increase, you get glucosuria, and you get and also from the fetus. We monitor the fetus because we know how much fetus is getting. Okay, so the normal sugar intake in the placenta is somewhere between 6 milligram per kg per minute to 8.
Yeah.
Okay, but what you want the baby to do in addition to same placenta rate. So if you give 6 to 8, you will maintain the growth in utero. Okay, right? But when the baby born, what you want to do? In addition, you need, if you give 3 to 4, you will maintain the metabolism. If you will give 5 to 6 to 7, you will maintain metabolism and the growth. But what else you want the baby to do? In addition to grow, metabolism, what else? Muna,
Brain activity.
Grow, including building subcutaneous fat. Yani this is growth.
you need them to do catch-up growth.
Gotcha.
Okay, so the best way to do catch-up growth is to give between 8 to 10 milligram per kg per minute. Okay, so if the weight, Muna did not weigh the baby yet because she didn't tell us whether she weighed the baby or not. So I personally would start with 7 milligram per kg per minute. So if you multiply 7 times 60 times 24 times the weight, you will get how many grams? And if you multiply it by the total fluid and you divide it by the percentage, divided by 100, you will get the percentage. So you have to select the percentage depending on glucose intake. And I would not advise at all to start with 5%. The more, the better. The more, the better, but the least would be 10%, and you have to calculate. You might need to give more than 11, but at the labor room, you either have 5%, 7.5%, or 10%.
Yeah. Yeah.
Okay, so remember these 2 factors. Okay, prevent decompensation, metabolic decompensation, and placental infusion rate, because that's the only way that we can monitor the nutrition in babies. We don't have any other options. We don't know.
Yeah.
Okay, so you have a target when you give nutrition to the baby early. What are these targets? Muna.
Yeah. To maintain the growth,
Yeah, but what is the target?
prevent
The objective
hypoglycemia.
targets.
Yeah, prevent hypoglycemia.
Yes, no. Well, if you cause hypoglycemia, then your care is not. No, you don't have hypoglycemia. But what is the nutritional target you want to achieve?
I want to meet the baby's metabolic demand.
Yeah. So I'm going to tell you, you need one of the target that another pillar is the day of achieving the birth weight. You know that the birth weight, the weight will drop,
Yeah.
and then you will achieve the birth weight. So
Yeah.
if you achieve the birth weight by day 7, you're doing great.
Yeah.
If you achieve the birth weight by day 14, you are not doing that good. If you achieve the birth weight after 14 days, then you need to review your practice.
Yeah.
So this is another reason why you need to give a good glucose. Okay, so you started D10, you started 80 ml per kg per day. Okay, and you hit the baby, you're very good. You hit the baby, the sugar hit the baby by age of 13 minutes.
Yeah.
Okay, so you're doing great. So that's your another pillar. So remember the pillars, right, Mona? You remember them?
Yeah, the temperature, antenatal steroid,
Okay.
antenatal steroid,
Okay.
antenatal magnesium sulfate,
Okay.
and glucose.
Delayed cord clamping.
Delayed cord clamping. Yeah.
Starting CPAP, variable flow within 2 minutes.
CPAP, with yes, early CPAP.
Yeah. Sugar hit the baby before 10 minutes.
Yes.
And what else?
And
What's
caffeine.
another pillar?
Caffeine.
You need to
Early
give
caffeine.
Why?
Within 20 minutes.
Why?
We need to give caffeine to stimulate respiration, prevent
You
apnea
need
of
to
prematurity.
give caffeine to stimulate respiration. But what happens if the baby is on CPAP and he's breathing? What happens if you don't give the caffeine?
Baby might have apnea.
Yeah, so what apnea will cause?
Apnea will cause hypoxia, and then.
So what you'll do?
So I will
when there is
start
apnea?
caffeine. Early caffeine.
No, suppose you didn't start caffeine and the baby got apnea. What you will do when the baby got apnea?
I will increase CPAP, and then I might go
No
to
response.
Yeah, no response. Then I will go for intubation.
Yes. So you want to prevent intubation.
Intubation. Yeah.
Because 50% of intubation due to apnea.
Yeah.
Yeah, so that's the reason why I want to start caffeine, to prevent intubation. Because one of the pillars to go with non-invasive is start as, because 50% of intubation is due to apnea, not due to surfactant.
Yeah.
Okay, so you want to start caffeine as early as possible. So that's another pillar, remember it.
Yes.
Okay. So now you started the caffeine hit the baby before age of 20 minutes. And then the baby saturation now, you are on 31% of FiO2, you're on a CPAP of 8. The baby is working a little bit of respiratory distress. You have your peripheral IV, you start your sugar, you started your caffeine. Now you decide to move to an ICU. What you will do before moving to an ICU? And these things you will do is a predictor of your good performance.
I will revise what we have done before moving to an ICU.
Okay.
We'll like debrief the team.
You'll for the baby. What are the pillars or the things that you will do before you move to the baby? A test,
I will
anything.
I will make sure that the infusion is running. The IV lines are maintained. Yeah. And I will maintain the CPAP.
CPAP is maintained. Saturation is, as I told you, is now at age of 30 minutes, it's 91%.
And I'll make sure the incubator is warm.
Warm, and what else?
Which was set before delivery.
Warm, and what else with warm?
Humidity also.
Oh, humidity. What's the humidity you'll use?
90%.
So you'll start at 90%. Okay. So now the temperature of the incubator is 36. The humidity is 90%. And what is the test that you will do on the baby before you move? Or let's say when you arrive, if the NICU is very close?
Glucose And check temperature.
Yeah, you check the sugar level. You need to check the
Yeah.
sugar level. Okay, so
Mhm.
one, sugar level. What else?
Temperature.
Temperature. So these are your pillars. Another pillar. Sugar level and room and the baby temperature on arrival to NICU.
Yeah.
So saturation at NICU arrival, one.
Yeah.
Sugar level at NICU arrival. Third, temperature of the baby at NICU arrival. This is another pillar of good performance.
Yeah.
So remember your pillars of improving work, right?
Yes.
Now you arrive NICU, but you didn't give surfactant. Why you didn't give surfactant?
It's not an emergency medication, so
Why?
I can give it later.
Why?
And the baby is maintaining good respiratory effort on CPAP.
If the
So I
baby is
can-
not maintaining, you will give.
If the baby is not maintaining, yes, and he's working more, requiring higher
Yeah.
CPAP, then I might give
So
surfactant
let's say the
in
baby
the
was
NICU.
working hard and you intubated the baby at the labor room. Will you give
Yeah.
the surfactant? And when? And
No,
why?
I will give it after I arrive to the NICU.
Why?
I will give it after stabilizing the baby. It's not
Baby
it's not a
stable.
rescue medication. Yeah.
Baby is
After-
stable. But why, when you will give it and why? Baby is stable.
I will give it within the first hour, but after I go to NICU.
Why? Do you want help?
Yeah.
Okay. Dr. Hiyam, Yamiz, Anud,
Mahmoud
Hisham,
Atiyah. Mahmoud Atiyah is there.
Mahmoud.
Yes,
Mona
Dr.
want to
Yahya.
give the surfactant after arrival in ICU. She want to give surfactant between 30 minutes and 60 minutes of life. Can you tell her why? Or Mahmoud need help. Hiyam, can you help him?
If the baby is on CPAP and FI2 above 30
Baby
for 1 hour, this is
now in the labor room. Okay. Will you give surfactant? When and why?
yeah. If the baby on CPAP and FI2 30 and above, I have to give for
Baby
1
is
hour.
intubated. Yeah, Hiyam.
Intubated. If the baby is intubated and he's stable and maintaining temperature, everything, I will leave
Stable
it
and
in the.
maintaining temperature. When you will give surfactant?
I will give surfactant after shifting the baby to NICU, and
Not after
whenever
moving.
the requirement of FI2 exceeds 30. You mean?
The baby is intubated now. Baby is stable.
Yes.
FI2 requirement is 35%. The question, when you will give surfactant?
Yeah, within
and
the first
why?
hour. Yeah, because FI2's requirement is above 30 and the
I
baby is
don't
already
want
on
to ask
mechanical
you, I'm
ventilation.
not asking
1
you,
hour.
will you give or not?
1 hour.
No, we
Within
decided
1
to
hour.
give. Dr.
Yes.
Hiyam, we
Yes.
decided to give.
Within 1 hour. Yes.
So when and why?
When within 1 hour?
Within 1 hour. Like in the first minute of 8?
In 59 minutes maybe.
Okay, so why 59? Anybody want to help them? Anybody want know the answer and why? Anybody want to help from the audience?
Yeah, can I answer that, Dr. Yahya?
Yes, go ahead.
I think it's done between 30 minutes and 2 hours because you need to help the baby achieve the functional residual capacity first.
Excellent.
And then
What's
give
your
the
name? Who's speaking?
Sarmat.
Yes, you need to achieve the functional residual capacity. You need to open the alveoli because the surfactant can go easy to the open alveoli, where it's very difficult to go to the closed alveoli because the surfactant moves inside by 3 forces: positive pressure, negative pressure, and surface diffusion. And all these, you want to use not positive pressure because you cause more injury. You want to do negative pressure, the baby suck the surfactant in. And that's another reason why you give caffeine. You want the baby to be spontaneously breathing, even if you intubate. Because when the baby breathes, he or she wants to open the alveoli. So she will suck the surfactant to the closed alveoli. And the second is that you want the surface diffusion to bring the surfactant to the open alveoli, and you want to avoid pushing the surfactant in. So to do all that, you need to achieve a good functional residual capacity. In other way, you recruit the alveoli before you give surfactant. Okay, Dr. Ramona? Dr. Ramona? معايا ولا لسه؟
Hello? Yes, yes, Dr.
معايا؟
I think I was muted. Yeah. Yes. Nice.
Do you know why we give it between 30 minutes and 60 minutes?
Yeah.
To achieve a functional residual capacity.
Yeah.
You don't need to give surfactant before. So the
Yeah.
other reason why we give caffeine is that when the baby is spontaneously breathing, even with intubation, it will help us to suck the surfactant in. So that's another reason why you give caffeine. The third reason, the surfactant causes better movement of the diaphragm. So it will help us also with the surfactant administration.
Yeah.
Even if you decide to give by Ensure, for example. And that's the reason you don't give surfactant immediately. So the immediate things is the sugar, the temperature, the saturation.
Yeah.
Okay. So anybody has any questions so far to Dr. Ramona, Dr. Rola? Any question from?
We have raised hands by Dr. Inayatullah and Dr. Sundus. If you may please give your comment. Sundus and Inayatullah.
Yeah, yes, Dr. Yahya. Before we give surfactant, it's better to ensure the ET tube position in order not to give surfactant only to the right lung.
Yeah,
You should do-
no, we're assuming that Mona intubated the baby, and she is not selectively intubate one side. And Mona, I think she has a good experience that to check that the air entry is bilateral,
Yes,
and also she
symmetrical.
will look to connect the baby to the ventilator. She will see the graphics and loops, and
Yes.
she will make sure that there is no leak. And she might have a calorimeter to detect CO2, and she might have end-tidal CO2. So I think Mona have a facility to check that she's actually extubating and intubating the baby correctly, not selectively intubation. But if you ask, should I do X-ray or not? Mona
Yes,
will ask.
you should.
Mona
Yes.
will answer the question.
Okay.
Well, I will do X-ray, but we can do an ultrasound to confirm the position.
So is it a
But
must?
I will do X-ray. No, it's not. If I'm sure about the ET tube position by calorimeter and length, then I can wait for the X-ray.
Okay, but is it a must? Yes or no?
Well, in our practice, yes.
Okay, no, it is not a must. You don't need
Yeah.
to do X-ray to give surfactant. Okay, there are
No,
many
not
ways.
to patents. Confirm only the position, to document the position of the ET tube.
If you
At
want to
least-
keep the baby ventilated, then yes. But if you want to give
Yeah.
issue, you don't need to do that.
Yes, yeah, of course,
Then
yes. If
even you
it's
don't need
unsure,
to
no.
fix the tube. You don't
Yeah.
need to fix the tube. You can give.
Yeah, if I
But
need
what
to
is
fix
the
the tube, then
definition
I
of
will.
ensure, Dr. Ramona?
It's intubation. We give Cervanta and then extubate the baby and put
Okay,
in
but
CPAP.
intubation, put the baby on ventilator and give surfactant also. Same. But so what is the difference?
That we will intubate and give the Cervanta and extubate the baby at the same time and put in CPAP.
What does same time means?
Like after I administer Cervanta.
Yeah, so if you
Immediately
intubate
after
the baby and you give surfactant after 2 hours, and then intubate the baby and you give surfactant after 1 hour, which one is insured? Both of them, you intubate, you give surfactant, and you extubate. Which one is insured? Which one is not insured?
Ensure is extubate after 1 hour
After 1 hour, insured.
or earlier. Actually, not even 1 hour. It's immediately.
What is immediately means? 1 minute?
Yeah, after I finish administering Cervanta and I'll remove the tube and put the baby on CPAP.
I know the process, but the question
Yes.
is, the question, I know the process. I know you know the process,
Yes.
but my question is not
At
that.
the
My
same
question is-
setting, like I will not wait. I will not keep the baby on intubated on ventilator after.
but you want to check the
administration.
tube level.
No, because I will remove the tube.
I know, but how long you should wait to check the tube level by X-ray? Minimum.
No, if I'm intubating, I confirm the position to do ensure. I will not do X-ray to.
So you said it's a must.
Yes, it's a must if I will keep the baby ventilated.
No, you're giving insure. Do you check by X-ray?
No, not necessary.
Not necessarily. Why?
No. Because I will confirm with air entry and calorimeter.
Yeah, so
that
you can
it is
confirm. The reason is, Dr. Amuna, because it's too long. So if you wait to do X-ray, you need at least, I don't know in your hospital for how long, but at least I would assume 30 minutes, at least.
Yeah, to wait for the technician to
So
arrive
if
and do
you
the.
need more than 20 minutes, this is not insure anymore.
Yes.
If you exceed 20 minutes, insure mean intubate, give surfactant, extubate. It should not take long time because you need a few breaths to cause lung injury. And so that's the reason why it's not necessarily, not a must, answering Sundu's question, is not necessarily to do surfactant. And intubation in one lung is not easy, is not difficult to determine. Any more question, Dr. Orula?
Dr. Yamin raised his hand.
Who?
Yamin, I think
يلا
he has.
يامن.
دكتور السلام دكتور يحيى كيف حالك؟
السلام ورحمة الله.
How we could monitor the baby's response to the Surfactant if he need the next dose or not?
So that's to me or because Mona is managing, not me.
Okay.
So to Mona, question to Mona.
Yes, doctor. Yeah.
How you monitor, Yamin is asking you, how you monitor the response to surfactant? Good question.
I will monitor the response. The
So
response will
let me
be
help you. I want you to tell him the immediate response, the intermediate response, and the long response. So he will have a very clear idea. What is the immediate response that you will monitor?
Immediate response, FiO2 requirement will drop.
Okay.
And baby will need less CPAP.
Okay. Well, you're still intubated. Are you giving surfactant?
Yes, I give surfactant and I extubated the baby and put him back on CPAP.
So is there anything that you will see while you are intubated?
Well, the baby will require less pressure after giving surfactant.
Yeah, so let's assume the baby connected to the ventilator. What you will see? Dana, do you want to help her?
Babies,
Yes, compliance.
Yes, the compliance
Yes,
will change,
compliance.
Doctora. So the pressure
compliance will
volume
change, yeah.
will go up, will turn to the
Yeah.
left. Compliance will improve. So that's immediately you'll see that.
Yeah.
Okay.
Yeah,
What
if
else?
baby is connected to ventilator, yes.
What else you'll see on the loops and the graphics if you're giving surfactant? Compliance will improve. What else?
Yeah.
Resistance.
The resistance, you'll see signs of obstructions.
Yeah,
You'll see signs of
resistance will
obstruction
increase.
because you're giving fluid.
Yeah.
Okay. And then you will monitor that the saturation will improve. The work of breathing will improve. Okay. The other thing, you will see that CO2 will get high because you're causing obstruction if you do gas immediately, or if you have a CO2 detector, tidal CO2 or transcutaneous CO2 monitor, you will see that CO2 will go up a little bit. And if you have NIRS on the brain, you'll see the NIRS will drop a little bit because CO2, you will see improvement, and then CO2 will drop after you finish. So you'll see a variability of the NIRS to the brain. So these are immediate response. Okay. So how you decide to give another dose? The question is for long-term response.
For long term, if FiO2 requirement is increasing again, or work of breathing is increasing,
okay,
or baby is requiring more pressure to
Okay, so when you will give next dose?
A time minimum of 6 to 8 hours.
Okay, so I would give after 8 hours. What is the evidence of the second dose? And what's the evidence of third dose?
Dr. Sundus has a comment.
Dr. Sundus.
I think if failure of CPAP after the first dose of surfactant, we should give the second dose. Failure of CPAP, criteria of failure of CPAP.
Yeah, she said that. She answered in this way. But my question to her is, what is the evidence, statistical evidence of giving second and giving third dose?
There is no evidence.
The second dose have very weak evidence. The third has no evidence. The evidence for the first dose, as rescue between 30 and 60 minutes, are stronger. Okay,
Yes.
so the baby arrived to the NICU. He was on CPAP, and you gave CPAP by Ensure, and you put the baby on CPAP again, variable flow CPAP. The temperature on arrival, unfortunately, was 35 by rectum, and your sugar is 3.4, and your sugar intake is 7 milligram per kg per minute. And your saturation, you are able after surfactant wean the FI2 to room air and your CPAP to 7 centimeter of water. And now you are 1 hour of life. What you will do?
Now, okay, well, I want to go for UVC and USC insertion, but
you
after I stabilize the temperature.
You want to insert central lines now, right?
Yeah, yeah.
Okay, what else?
Antibiotics.
Inserted central line successfully. What else you want to do?
Start antibiotics.
You have to do investigation, so you need to do work acceptance. What is the time frame for your work sepsis workup?
Time frame after like 1 hour actually.
1 hour is very good, but I would give you 2 hours. If you can do it within 2 hours and start antibiotics.
Well, if the baby is stable, yeah.
Yeah. So the surfactant within 30 minutes to 2 hours, the sepsis workup within 2 hours. Your lines, if you can give it, doing them within, if you have a peripheral, the time frame, you can delay them as much as you can. But if you don't have a peripheral, then you should target 45 minutes. Okay, so you have a central line now. You did sepsis workup, and you did CBC and culture, started antibiotics. What else? Another pillar. Now you have to mention to me another pillar. Did you forget anything?
HI.
Feeding.
No.
Feeding. Yes, feeding. Yes, very good. When you will start feeding? If you have the milk. You have DPM.
As soon as stabilize the baby.
What do you mean stabilize? I told you everything about your patient.
Yes, so far baby is stable, so I can start the feeding.
When? And where? And why?
When, like, if baby is stable after 1 or 2 hours, I can start the feeding.
1 or 2 hours. You want to wait 2 hours? Why?
Because during this time will be whether be like I'm stabilizing the baby, inserting lines.
What is stabilizing? You said
after that
and I'm ignoring it. You keep repeating it and I'm ignoring it. What does stabilize means? I'm telling you everything
like
about you.
I mean, baby started to maintain saturation. I gave him Cervanta. He started to maintain saturation. Then I inserted the line.
But the saturation and Cervanta is in the respiratory system. What has to do with the feeding?
Yeah. So as early, I understand it's as early as possible. So even in labor room, Dr. Yahya, I would like to start the feeds.
I would like to start feed at the labor room, actually.
Yeah. Yes.
Okay. So what type of feed you will give the baby?
Express breast milk.
You will give express breast milk, but there is no express. Let's say you have donor breast milk. How you will give? And why?
I will give 0.5 ml for hourly
You will give 0.5 ml, and what that's called?
trophic feed.
Trophic feed or minimal enteral feed. It's a donor
Minimal
breast
enteral
milk
feed.
or ABM if it's available. I don't like the formula. Is there any way, other way to give other than trophic feed? And what's called?
Gavage.
Yeah, it is gavage. You will be given by gavage. It's a minimal enteral feed. But if there is any other way of feeding the baby? So what is minimal enteral feed, Muna?
Dr. Sundus raised her hand.
Muna, what is the minimal enteral feed? Can you define it to me?
It's a 10 ml per kg of milk.
It is a 10 ml per kg per 10 to 20. I agree with you.
Yes.
That's one character. Okay. Second.
And it's 4 hourly.
No, it can be 2 hourly. It
least.
can be 4 hourly. It can be 6 hourly. It
At
can be
least
8
4
hourly.
hourly. Yeah.
So one character is 10 to 20 ml per kg per day. Okay, that's one. Another one. Mahmoud, do you want to help her? Dr. Mahmoud?
We have from
Yes.
Asma.
Only the fellows, Rula, only the fellows.
Okay, Doctor, ماشي.
Mahmoud, Riyam, Unood, where is Unood? Anybody want to define to me? Okay, fellows cannot define. Dr. Sundus,
Okay,
can you
doctor.
define?
Hello.
أيوة دكتور أحمد. يامن يلا
Yaman,
يامن.
This is extra amount of feed.
Minimal intra nutrition or minimal intra feed.
Same.
مش نفسه التروفيك فيه دكتور؟
Same trophic feed. Okay, what's the, how you define it? What is the characters of it?
يعني to use a small volume of human milk or formula.
Yeah, it is formula. She said formula. She said EBM.
To use a small volume. Yeah, to use a small volume of EBM or formula to priming the gut. To priming the gut.
All that. She said all that.
And it's not included in the intake.
Yes, it's a gift. It's
extra.
not included in the TFI. It's a gift. It's extra. So that's the second character. So she said 2. What else? There are 8. There are 8 characters. So it is 10 to 20 ml per kg per day. It is extra. What is the third one? Muna.
Yeah.
It is not for nutritional values.
Yes. Oh, yes, it's not for nutrition.
4. It can reach to the bowel. So it will reach to the stomach and the bowels.
Okay.
To prevent enteropathy. It prevent fasting enteropathy. It stimulates the hormones.
The hormones.
Yes.
To prime the gut.
It's priming the gut.
Less feeding intolerance.
It decreases the time, مثل أيمن, it decreases the time from feeding to full feed. Duration decrease. It decreases the complication of feed.
Improving weight gain?
No, it will not improve weight gain.
Non-nutritive.
Okay, so this is
tolerance.
Is there any other way to give milk? Toramuna?
Yes.
Yeah, what is it? What is called?
Way like by gravity, you mean gravity or pump?
No, not gavage. All it's MEF. By the whether you give it by gavage, pump, or it is a feeding tube. It's NG, it's OG. It's all same. It is no other way. If there is another way to give milk. So any of your audience want to tell us how we can give milk other than MEF?
Dr. Yahya?
Yes, sir.
By cream, I think, by...
Yeah, you can give the milk through the skin.
Yes.
Yeah, you can paint the body, the skin, with milk. So that's
Mhm.
another way. And you can do it as a cream, or you just do it as a milk.
Yeah.
So that's another way. Is there any other way?
Yes, Dr. Yahya, the oral immune, it is not
Yes,
rich
you
the
give the
gastro.
oral immune therapy. You give
Yes.
oral immune therapy. Dr. Amuna, how do you give the oral immune therapy?
Oral immune therapy?
Yes. What is the difference between oral immune therapy and MEF? Actually, I have a presentation in Paris next July. The difference between oral immune therapy and MEF. What are the difference? The name of the whole topic. It's about 80 slides.
Oh,
Yeah. So do you know what's oral immune therapy?
no.
Anybody want to help her from the fellows?
Is it probiotics?
It's not a probiotics.
Not a problem.
I don't give a probiotics. I think it's a dangerous. Probiotics is dangerous, I think.
Yeah.
Never give probiotics. Do you know why? No, we don't give probiotics. You know, some people give, but do you know why I don't give?
No.
There is no standardized dose. There is no standardized vector. There is no standardized type of bacteria. And it can turn pathological. It's a bacteria. And it's a very weak baby, immunocompromised. Even normal flora can turn pathological. So I don't give very tiny immunocompromised baby a bacteria, whether it's benefit or not. I will never give it. I don't do it. Anybody knows what's MEF?
Minimal enteral
Is it
feed.
the colostrum? Giving the
MEF,
colostrum?
sorry, no, oral immune therapy. What is the difference between MEF and oral immune therapy?
Is it giving the colostrum?
No, you can give the colostrum through MEF. Okay, so let me answer you. First, it does not reach to the bowel.
Okay.
One. Second, it is 0.2 ml every 2 hours.
Okay.
Third, it is you make it as a drops. So 2 to 3 drops in each angle of the mouth, and it will be absorbed from the mouth before reaching the bowel.
Okay.
And it prevent the dryness of upper airway.
Yeah.
And it prevent the infection because it have antibody and all the factors in the mouth that prevent the infection going through and colonization of the upper airway and colonization of ETT. And it's not used to prime the gut. And it has very soothing effect. And it's very good analgesia.
Yeah, of course.
Okay, Dr. Ramona?
Yeah. Okay.
Okay. Should I leave you and move to another case, or should I stop here?
I have a comment from
Yeah,
Asma.
go ahead.
If,
Go ahead.
If EBM is not available, then you will use formula, full-term formula.
No, if I want to use MEF, I will use full-term formula, or I can use, like some people use only dextrose. I can use TAM. We cannot use very high calorie density formula because the purpose is not nutrition. So using high calorie is of no use. So the purpose is to prime the gut. So you need to prime the gut with a low calorie formula. So I will use TAM formula if it's MEF. But I will not use MEF TAM formula for the oral immune therapy. I use it only for MEF.
Okay.
Should I leave you, Dr. Amuna, or you want to continue?
As you wish, Dr. Can continue.
Okay. So any volunteer for next case?
If no volunteers, I'm happy to continue.
Dr. Yahya.
Yaman, you want to volunteer?
Okay.
Okay. 22 years old, primary pregnant with 38 weeks in active labor, but no progress, antenatal bleeding, decreased fetal movement, not, she is inactive, not in labor, and planned for C-section. I mean, not delivered, not in labor, not delivered, and planned for C-section. Is that okay, Yaman?
38 weaker active labor, okay. Decreased fetal movement, not in labor, planned for C-section. Okay.
No, not delivered. No progress. Okay?
All right.
Okay. So what do you want to do? Now, let's say they are preparing and they call you, they will do C-section. Okay?
Yes.
Okay, what do you want to do?
So first of all, we'll just get a brief history from the obs-gyne side.
Okay, you ask me, I will answer you.
So the maternal condition regarding if she is hypertensive, diabetic, any
She's not
comorbidities.
hypertensive, she is not diabetic, but she is bleeding.
Okay. The amount of bleeding and since when she is bleeding?
She was bleeding now is 6 p.m. and she was bleeding from 3 p.m.
Did she sustain any trauma or just spontaneous bleeding?
No trauma.
No trauma. Okay. So mother general condition, is she any on any drug medications, anything?
No, she is not on medication.
Is she a booked case or just arrived to the ER and unbooked case?
No, she is an emergency.
Okay, and she's primary.
And she's primary.
Okay. The estimated fetal weight?
خلاص يا عم عملوا الترا ساوند و3 كي جي يلا خذنا يعني مش حتخلص هالمعلومات يعني.
Okay, doctor. So we'll prepare our the equipment for the expecting unwell delivered baby since there is poor
You don't
progress.
want to do anything before preparation?
Then I will take the I will take a staff with me from the NICU unit.
Ma'am, I don't hear you.
I will take a staff nurse from well-trained staff nurse from the NICU units.
So you will gather your staff and
Yes.
you will prepare your resuscitation room. Like assume you already prepared.
Yes.
You want to do anything else before the C-section?
Check my equipment, prepare my equipment.
Ready, you're ready, you're prepared everything.
Warm the temperature, room temperature.
Not very important in this age.
Okay.
He's not he's 38 weeks.
38 weeks, okay.
Do you want to speak with the mother?
Yes, I can counsel the mother.
Oh, you want to speak if there is time, you want to speak with the mother. Okay, so you want to prepare your equipment. What the most important equipment you need to prepare in this case?
Most important equipment?
Mm-hmm.
So the
Bleeding,
equipment.
bleeding,
So,
decreased fetal movement.
yes, I have to expect that patient in hypovolemic shock.
Yes, so you might need advance. So you need to prepare UVC for low access.
Yes,
because there will be
yes.
no time for trials of peripheral. So you
Yes.
need to go for low lying or low level UVC and prepare. The expected weight is 3 kilograms. So you prepare 20 ml per kg bolus, right?
Yes, of normal saline.
Yes. Okay. So you need to prepare. What else you want to be ready for?
So I would
Adrenaline?
expect that patient he suffered hypoxia in utero.
Yeah, decreased fetal movement. So there might be antenatal asphyxia.
Asphyxia, yes.
What is asphyxia?
This perinatal asphyxia, this is a lack of oxygen or oxygenation supply.
Asphyxia is lack of oxygenation. So what is then hypoxia and hypoxemia? If asphyxia is lack of oxygenation.
No, this is
Do you want help?
I think Liam is ready to give some answers.
So Hiam, do you want to help him? What is asphyxia?
Lack of oxygen or blood flow.
So what is the difference between asphyxia, hypoxia, hypoxemia, and desaturation? You have 4 terms.
Hypoxemia is in the blood.
So hypoxemia, low oxygen in the blood. Okay, hypoxia.
Yes. And the tissue.
Hypoxia in the tissue. You sure?
It is other way around. Hypoxemia to the
No,
tissue.
hypoxemia, emia, hemoglobinemia, emia is in the blood. He's right.
Yeah.
This is hypoxia. Hypoxic respiratory failure. Have you heard about it? So hypoxia is low oxygen in the lung, in the environment. So what is asphyxia then? Yeah.
Asphyxia, it's hypoxia and hypercarbia and and lactic acidosis. This is all. يعني turning the metabolism from aerobic to anaerobic.
Why these all happen?
The sequel.
Yeah,
Hypoxic bone.
this is
When the baby hypoxic bone, what is the character on this baby?
Asphyxia is oxygen deprivation.
Oxygen deprivation. Why? What happened?
When the oxygen is not there, the metabolism will be turned to anaerobic.
Okay.
From
So,
aerobic to anaerobic.
let me answer the question. It is inability to initiate or maintain spontaneous breathing. That is hypoxia. Inability to initiate or maintain spontaneous breathing result in hypoxic and hypercarbic respiratory failure. Okay? And lead to hypoxia and ischemia and multi-organ failures, and it's characterized by many things. So again, hypoxia is inability to initiate or maintain spontaneous breathing. That is hypoxia. When you say baby hypoxic, his baby is not breathing, baby floppy. You use this term, baby bradycardic. So he's asphyxiated, okay? Because his inability to breathe. Now the causes antenatally due to lack of oxygen, as Yaman, or it's natal or it's postnatal. Antenatal can be acute or chronic, natal usually acute, and postnatal can be acute and chronic. The baby might be asphyxiated, Dr. Yaman. So what you want to prepare for?
For cooling.
Cooling, how you'll do the cooling? Yes. All right. How you'll do cooling?
In the labor room, I will turn off the thermal.
Yes. So you want to do a passive cooling, okay, not active. So you turn off the incubator expecting the baby will be, so you don't provide thermi. Okay. So now you're ready. The baby born. What do you want to do?
I will do my assessment, Apgar score.
Oh, you'll do Apgar score, Yaman, in baby who's asphyxiated.
Okay. I will do cord pH or skull pH.
Yeah, well, somebody else will do the cord pH, not you. But this baby is born. What do you want to do? NRP.
NRP, yes. I will secure my airway, breathing, and circulation.
No, you don't secure your airway, Dr. Yaman. First 5 steps in NRP, what are they?
5 bag inflation. 5
dry.
Inflation.
Dry.
Yes, okay. Dry the
position, yes. Suction, right?
Yes.
And stimulate. These are the 5 things you do, whatever the condition of the baby. Right?
Yes, yeah.
So you ask 3 questions before. Is the liquor clear? Is the baby term? And if the baby is heart rate.
Yes, yeah.
So these 10. And then you do dryness, stimulation, suction, position. Okay. And then 30 minutes, 30 seconds, and you assess 2 questions. Baby breathing and what's the heart rate. Yes, and now you take another action. What will be the action? So you dried, you stimulate, you suction, you position, and
now
you want the baby.
Is the breathing, how is the heart rate?
Yeah, so the heart rate now below 60. And the baby is not breathing. You are 30 seconds.
Okay, again, I will reposition the baby. I will look for if there's any secretion in the mouth to do suctioning under vision.
No, you did suction, Victor. You did suction, you dry, you stimulate, and it's 30 minutes. Who's this? Sir, can you mute yourself? OMI, AG, some abbreviation name. So what else you will do, Dr. Yaman?
Yeah, I will do another assessment. I will reposition the baby and I give another set of 5 inflation.
Yeah, so you will start to ventilate now. baby is not breathing, and the heart rate is below 60, you need to ventilate, right?
Well, according to the NLS, we have to inflate the lung, then to ventilate. NRB, I'm not aware about the NRB.
You want to inflate the baby? Baby is not breathing.
No, but we have to secure make sure that the lung is inflated by having a good observing of the chest raising. If there is no chest raising, so we cannot go for ventilation. This is the protocol for the NLS.
You do sustained inflation for baby who's not breathing?
We will not move to the next step of ventilation till we have a good chest rising.
Yeah, so you ventilate to see the chest rise, right?
No, ventilation after good chest rising.
I think you also means positive pressure ventilation, you mean, صح?
Yeah, not sustained and ventilation. He
So
doesn't
I
mean
don't
sustained.
understand. So he wants to see chest rising without ventilation. How?
No, he means he will give 5 breaths.
Positive pressure ventilation.
Yeah, so you will put ventilation.
Yeah, positive pressure.
Positive pressure ventilation.
Yes.
So you will start to ventilate by something, right? Either flow inflation bag or self-inflation bag or Neopuff or resuscitation or whatever you are using.
Yeah.
You will get, start PPV. Now this PPV can be prolonged, can be short, whatever, but you need to ventilate because you did your positioning, stimulation section. Now you need to ventilate. Okay, so provide ventilation. And the ventilation should be effective, which means there is good chest rise, right?
Yes, yeah.
Yeah, so now you provide positive pressure ventilation. Well, how much FI2 you will give? During your ventilation?
21%?
You start with 21%.
100%.
100%, yes. Okay, the baby is in shock. So you start with 100%. So you start with 100%. You are giving PPV through self-inflation bag. At 30 minutes, there is a good chest rise. The color is improved. The saturation is a little bit improved, but the heart rate is below 60.
So again, we can give a bolus of a normal saline.
You gave already. You prepared. Somebody is doing the central line. You are ready, and somebody is doing the line to give the bolus. You're giving PPV through self-inflation bag on 100%. The saturation is improving, is around 60%. You've checked the heart rate at 1 minute and the heart rate below 60.
Then we'll start CPR for the baby.
Yeah, so when you do CPR, what you should do before CPR for the airways?
We'll put a good airway and ask for help. Somebody should bag, and some other one he will do a chest compression, 3-to-1 ratio.
How you bag? Through what?
Ambu bag.
You will do and you will do chest compression.
Our new puff.
Or use a new puff and chest compression. Do you want anybody should help Yamin?
Yeah, you will secure the airway by intubation, and then another one should be assigned for chest compression.
You need to intubate before you do chest compression. If you're, you need to intubate because you will never able to achieve good, effective chest rise, as you said, good ventilation, effective ventilation without intubation. So you intubated the baby, and somebody start to give PPV with 100% FI2, and you're doing chest compression. Okay, after 2 minutes, the heart rate now is 71. You put an EEG on the chest and the heart rate is 71. What you will do?
Medication now.
The heart rate is 71. You're doing PPV through ETT tube and you're 100% oxygen. You put an EEG, the heart rate is 71. The saturation is 79 and you're giving PPV. And you are doing chest compression. So what you will do right now?
Medication.
What type of medication you will give?
Epinephrine.
You sure?
Heart rate is above 60.
The heart rate is 71, Yaman, by EEG.
Okay, we'll continue ventilating the baby. We might think on another bolus. We'll check the blood pressure.
But somebody is doing chest compression.
We'll stop the chest compression and we'll check.
We'll order that to stop chest compression.
We'll check the heart rate again. Check heart rate once.
Yeah, so at age of 3 minutes, the heart rate is 110, and you are giving PPV, and you're on 100%, and the saturation is 94. The baby is not breathing. Somebody inserted the UVC low level, and the normal saline bolus are going through. You already turned off the incubator temperature, and now you are about 3 minutes. Okay, or 3.5 or 4 minutes, let's say.
Yeah, yes.
Okay, what's next?
We'll check the blood sugar.
You'll check the blood sugar. What else? The blood sugar is 6 millimole per liter, per deciliter, afwan.
Okay, now after stabilization, we can shift the baby to the NICU to continue
You
the
will
management.
shift the baby to an ICU. Okay.
Okay. Now this baby, first of all, we have to be careful with the fluid management. First of all.
So how much fluid you will give?
I will go with the 60 ml per kg per day.
So you will restrict the fluid.
Restrict the fluid, even less.
We'll give
yes.
less. Yes.
We'll give less. Okay. What else?
We have to check his fluid
Cooling
and
criteria.
Yes. Yeah.
Criteria
thank you.
for
So
cooling.
help Yaman. So you will do a cooling criteria. To define asphyxia. The baby's asphyxia. But when the baby is asphyxiated, you need to do cooling. And the asphyxia is mild, moderate, and severe according to which classification?
Sarnet classification.
Sarner classification. Okay. So what are the criteria in general that is eligible for cooling?
Birth, gestational age above 35 weaker.
Well, your baby is 38, yeah, Yaman.
لا أنت تقولي criteria تسألني لا.
This is your baby.
Okay. So he's
group
38
1,
weaker.
group
He's
2, yeah.
full term. He's full term.
He's 38, yeah, Yaman.
Yes, full term, 38.
Yeah, okay.
And having a history of acute perinatal insult with severe abruptio placenta
Yaman.
because of bleeding.
Yaman.
No, doctor.
Dr. Yaman, your baby antenatally bleeding. There is decreased fetal movement. He was born flat. You give normal saline bolus. He's 38 weeks. You turned off the incubator. You restrict the intake. Will you cool or not? And why?
Doctor, I thought you were asking what is the criteria of calling. That's why I'm answering the criteria.
For your baby.
For baby, I will straightforward call him.
Why?
I will call him.
What is
because we have 2 group of criteria. We have to take one from each group at least. If the baby needs group 1, if the baby needs resuscitation more than 10 minutes, if the initial blood gas is showing acidosis, pH.
So does he need resuscitation more than 10 minutes?
I think yes, definitely.
Yes, so that's one criteria.
This one criteria.
That's another one. Okay, what else?
If we do blood gases and the base excess more than
no, ask me, I will tell you. Don't assume.
Okay, tell me the initial blood gases for the baby.
Okay, before the blood gas, do you want to ask another thing?
Yes, the other criteria, if the baby clinically has any picture of encephalopathy, posture.
Is another criteria, very important, vital.
Any abnormal movement, any seizure.
This is a clinical.
I will tell you, but before that.
Yaman
said it the first time he told us about. When he started the scenario, he said something, if you remember.
Gestational age, يعني?
He's 38 weeks.
Yeah, خلاص, he's already eligible.
What else you need? Something is very vital, very thing. Come on, we do it for every labor.
Apgar score. Yeah, this is
Apgar score. So what is the Apgar score? You want to ask me what is the Apgar score, or you don't want to ask me?
Then 5 at 10 minutes.
Yeah, at 5 minutes. How much it was?
Yeah, so at 1 minute the Apgar score was 1. At 5 minutes it was 4. At 10 minutes was 7, and 15 minutes was 9. Yaman.
Okay, but he required mechanical ventilation now.
So the Apgar score is 1, 4,
Hello,
7, and 9. Don't assume. I'm giving you facts.
9 at which minute?
Minutes cam, doctor, at 10 minutes?
1, 4, 7, and 9.
Type 7 mean at 10 minutes criteria. 7 at 10 minutes. It's not one. It's not one of the criteria.
Yes, so
Should be
this one is
5
removed.
and
What
below
else?
5.
What else you want to ask me?
Blood gas, pH.
Blood gas, pH is 6.98,
So
PCO2
this,
is 5, and
this
bicarb
another.
is 10, and the base excess is 19.
This is 2 criteria already in the blood gases: the pH and the bicarb and base excess. Sorry.
Oh, okay. So what else you want to ask me? Yamin said abnormal movement. He has increased tone.
Signs of encephalopathy: increased tone, reduced tone.
No, don't assume. Don't enumerate. You ask me.
Okay. How the baby
Ask
clinical? What's the posture?
So according to SARNet criteria, we have the primitive reflexes and we have the parasympathetic reflexes. So this baby needs mechanical ventilation after 10 minutes of resuscitation. So he's not breathing.
There is central line.
He's on ventilation.
Yeah.
Yeah, we need to check the pupillary reflex, sucking reflex. We don't know, and so
You
this
couldn't
is the main
check that. You tried to check
and
you tried to check the pupillary reflex. You couldn't do it, and he's intubated. You
Yes.
couldn't do the second reflex. What else? What next?
yes, will attach to CFM machine.
Okay. Why?
So to get us the reading, is it severely
Okay, you
abnormal or
attach to the
moderately
CSF
abnormal,
machine.
or is it not?
You attach to the CSF machine.
Sorry,
Yeah,
Doctor?
I want the vital things to be done. I want the vital things. I'm answering you. Yeah, let's assume you attach the CSF.
Okay.
What else? Will you cool or not?
Will you start
Fulfilling, who is fulfilling criteria of
Yeah,
cooling?
what you will do
No,
then?
that
He's
is khalas,
fulfilling
no
the
doubt. We
criteria.
are
What you will
cooling.
do?
We are cooling.
You are cooling. You
No, we
didn't
are
tell-
cooling.
So you start cooling. Okay? Yaman.
Yes.
You will start
Yeah.
cooling.
We agree, doctor. We agree from cooling from the labor room.
I did not agree with
He's
you.
going for cooling.
I did not. We started
Okay.
passive cooling. I did not agree with you.
Okay.
You said cooling, you said passive cooling, and you did not say, don't do that in the exam, by the way. Be careful. Huh? You did not say cooling. I never heard you. Anybody heard Yamin say he will start cooling?
He mentioned only the passive cooling.
Yes. He mentioned we will start cooling, but we're discussing the criteria of cooling.
Yes, we're
to
discussing the
confirm.
criteria, Doctor.
So your
Asia.
baby is eligible for
Is-
cooling or not?
Yes or no? That's
Yani you
that
didn't
was the
ask,
question.
you asked, is he eligible? We said yes. What is the
He's
criteria? We start
eligible. So
discussing
will
the
you
criteria.
start or not?
Yes, I'll go for definitely. I will
Yeah,
go
so
for
you
cooling.
start cooling. How? Explain to me. What type of cooling you will use?
يعني total body ولا شو؟
Yeah, yes, he's asking what type of cooling you will use, Yamin?
Yeah, total body cooling.
Total body cooling. What type? Like what type you usually use in your unit?
The mattress, you putting them, wrapping the baby with a
You have a
mattress.
machine deliver active hypothermia, right?
Yes.
Yeah, what other type, Hayam, other than the machine deliver? Hayam.
أيوة دكتور يحيى. We
أيوة.
can use a blanket according to the
a blanket
availability
or
in
a
the
mattress,
unit.
it's all machine delivery, but is any other type of cooling if you don't have machine?
There is that the IV fluid will be cooled, and I don't know the exact protocol. يعني,
No. We call it cheap technology cooling.
Yes, this is yes, that's what I mean.
Cooling. You can use phase variable. You can use ice bag. You can use
cool anima also. But
yeah,
this
you can use many
this is
things
on the
to
way.
cool the baby. So, but you have a machine delivery, active cooling, and Yamin started the cooling. He's on IV. He restricted the fluid. The baby is ventilated, and we did the cord gas. He has his Apgar score, and he connected the CFM. Anything else you want to do, Yamin, if I forget?
You should collect coagulation profile as a baseline.
Let's ask Yamin. Yamin, what do you want to do?
Yeah, send for the coagulation profile and metabolic workup for electrolytes and glucose. Monitor the vitals, and we connected to CFM machine already. So I will do insertion for UVC and UAC to monitor invasive blood pressure. I will attach nerves to the cerebral part and to the somatic part.
Okay.
Then I will observe if there is any abnormal movement, if you start having any hypertonia or seizures.
I told you.
Yeah, I will give him a dose of phenobarbital 20 milligram per kg as a bolus.
You will give لحظة يا من. You will give phenobarbital or phenobarbital, and why?
Yeah, phenobarbital is the active form of the.
So which one you will give? If you
phenobarbital.
You will give phenobarbital, not barbital.
No, barbital.
Okay. Why? Any other fellows? Mahmoud, where is Mahmoud?
I think he's on.
Mahmoud is never answer me. ولا عنود. So far, phenobarbital or barbital?
Really, I don't know the difference between phenobarbital and phenobarbital.
Barbital.
Okay, so you will give phenobarbital. Why?
The active form.
Okay, why you want to give active form?
To control the seizure.
Yeah, both will control the seizure, but why you want to give the active form?
Bypass the first liver.
Yes, Rula, don't speak, please.
I don't want to speak.
Don't speak. Because it's a multi-organ failure, Yaman. You don't want to load the liver. The liver will be affected too.
Yeah.
So that's the reason we use a phenobarbital if available, not phenobarbital, because you will damage the liver. You will injure the liver. Okay. So you started your phenobarbital because you don't have phenobarbital. I know your hospital. You don't have it. And okay, what else? Because I want to ask you, I don't want you to tell, oh, I said that. Tell me what exactly you do, because you are missing many things. You're missing about 40% of the management. What else you want to do? Any fellow want to?
I have to sedate the baby with the cooling.
You gave phenobarb, you will sedate the baby. But yes, I agree with you. You have to sedate the baby.
Yeah, because it's a painful process for the baby to bring down the temperature.
I don't know if it's painful, but you need sedate. Why you want to sedate? No, it's not painful. No, that's not the reason for sedation. Why you want sedate? Sedation has nothing to do with pain. Pain needs analgesia.
Because the metabolic rate of the brain.
Why you sedate? When you have asphyxia, what will happen to the lung?
The metabolic rate of the brain, because you don't want to consume more energy.
Yeah, you want to sedate the brain. You want to calm everything. You're cooling. You will sedate. You will stop the metabolism by cooling.
Yeah.
So why you do sedation? What happened to the lung?
Baby is ventilated, and it's good to be sedated, so he will not fight the ventilation.
When you have a respiratory hypoxia, what will happen in the lung? What's the complication? What's the common complication that we fear of?
Pulmonary hypertension.
Pulmonary hypertension.
Hypertension, yes. Due to hypoxia.
Pulmonary hypertension. You want to sedate because you don't want to aggravate the pulmonary hypertension. You want to make sure that oxygenation is good, a baby is sedated, temperature is okay, and glucose is okay, because all these will aggravate pulmonary hypertension. So you need to make sugar, calcium, temperature, oxygenation, and no movement for the baby. Okay? So you want to sedate the baby if the baby is ventilated. If you want to give analgesia because of shivering from cooling, so which medication you will use and why? Yaman. Arula, did we pass the time? Shall we stop?
Still, it is 7:39. We said we'll continue up till 8 p.m. يعني another 20 minutes.
But you guys are enjoying the session, or the session is boring?
Definitely.
Is the session is boring in this way?
No, it's really nice. No, it's really nice, Dr. Yahya. Please continue.
The sessions to be in a discussion mood.
Enjoying.
That's okay.
Okay. So Yamin want to give sedation. Anybody want to help him? Which sedation he will help? He already gave phenobarb, so that should be okay. But the baby need more sedation according to Yamin. Anybody want to help Yamin to select the sedation and why? What type?
Dexmedetomidine,
You
Presidex.
can give Dex alpha 2 agonist because it has less respiratory depressant. Okay. Yeah, and it does not interfere. It's not narcotic. It does not cause hypotension because most of this medication can cause hypotension. Yeah, so you can select that. But you can, if you decide to select narcotic, I will choose morphine, not fentanyl.
Yes, morphine.
You can use also midazolam if you wanted the sedation because you're already ventilated. Okay, so you started the sedation, Yamin. What else? Very important and vitals you're missing. You didn't do them yet. Anyone help Yamin? Did you do blood test?
Yes, of course. We need to send blood investigation.
Did you do, Dr. Yamin?
At time of inserting the central lines, I guess the blood was.
Oh, so he sent the blood investigation. He told me I will send the bleeding profile. I remember. That's all what he said. Or
bleeding profile as extra, yeah, because routine things, blood gases, and.
What is the routine? Okay, there is no routine in neonatology.
According to the scenario, the mother was having bleeding, so we are anticipating maybe the baby had
anemia.
Okay, so what you will do, Ahmed? Help
maybe
them.
DIC.
CBC, I need to send CBC cross-match. This baby may need
transfusion.
This mother was bleeding. And the baby has decreased fetal movement. What is the causes of decreased fetal movement?
Dr. Inayatullah has mentioned the capillary gas and lactate and CRP. This is an input from one of the audience.
I don't do CRP. It's a useless test. But the baby has fetal...
So, CBC
cross-match. You did CBC cross-match. What else? Yeah, you do it routine every day.
Renal, yes, renal function and liver function. Because hypoxia and...
what else?
You CK and LDH.
Yeah. Baby has decreased fetal movement.
Naam?
The baby has decreased fetal movement. You did lactate, okay. But your baby has decreased fetal movement and you get BBV for like 10 minutes, more than 10 minutes. The Apgar score was...
Electrolytes, you have to check the electrolytes, the minerals.
Yeah, you send electrolyte.
But what renal function, including the electrolytes, potassium.
Fetal distress other than asphyxia, what else can be?
I will do CK and LDH.
This hypoxia will affect the renal perfusion definitely. I'm anticipating renal perfusion will be affected.
No, Hiyam, let's assume there is no hypoxia. What else can be? It cannot be infection?
Anemia per se? Of course, yes. We have to cover it for 48 hours.
What is the antibiotics?
Blood culture.
Did you do blood culture?
Yes, we are doing by routine.
Yeah,
I mean, initially
so fetal distress cannot be due to infection?
Yes, Dr. Manal Abdussalam has answered blood culture.
Blood culture and start antibiotics. So you did CBC, blood culture, start antibiotics. Okay, what else you want to do, Yamin?
Yeah, then I will go by systemic review for each system. Like I have to manage target organ has been or suspected to be affected, like cardiovascular system, renal, and hematology.
Okay, ask me.
So what is the blood pressure right now?
The blood pressure is well, you didn't talk about the blood pressure, unfortunately. Good, now you remember. The blood pressure is the systole is 31 and the diastole is 9 and the mean is 21.
So I think we have to start on inotropic support for this patient.
Which inotropes you will select and why?
Epinephrine.
You will start.
We will anticipate. No, I will start. I will prime the circulation first with bolus, and I am thinking this baby may. We can still has hypotension and low heart pressure, so I.
Which
we don't want to overload
this patient. لحظة يا يامن بس we're thinking this baby had the impaired cardiac function because of the severe hypoxia.
How you know? Wait.
Yeah,
Wait,
pulmonary hypertension. So I will do hemodynamics if possible.
Yes,
I
so
will
you
go for
need
echo.
to
So
ask for
decide.
echo. You need to ask for echo before you start. There are
So
many
decide
reasons why
either-
you want to do echo.
Yeah, pulmonary
The heart is
hypertension is
abnormal.
suspected.
Maybe the heart, your heart maybe is abnormal, right? Maybe your PDA is closed. Maybe you have pulmonary hypertension. So you have hypotension and pulmonary hypertension, and the heart should be normal. And now you select your inotrope, depend on all these parameters. So you need to hemodynamic.
Urine output also.
You need urine output, lactate, NIRS if you have on the head. Okay, and then you decide your inotrope. So I don't want to do past the hemodynamics. So what else you want to do? You're still missing about 30% of management, Yaman.
Coagulation profile.
Yeah, he asked for coagulation. So how frequent you want to do
The
that?
DIC, yes, suspected.
How frequent?
According to the initial result.
Oh, so
That's
you
the
all
clinical picture.
okay? So ask me. Although it's not related, Yarola.
What was this PT and PTT? What was his INR?
INR is 1.1. What else you want?
PT and PTT.
PT.
But this is normal.
Both of them are normal.
Okay, خلاص, like 24 hours.
So you will leave the baby without blood test for 24 hours, Hiam.
Yeah, according, we'll see the CBC first, renal function.
CBC, ask me.
Type C, tell us hemoglobin, hematocrit,
Hemoglobin
platelet.
4.
4.
Yeah.
So definitely he's for transfusion. I think this one transfusion.
He's not asking me for. So the hemoglobin is 4. Ask me whatever you want.
What is the platelet?
Platelet is
because
110.
consumption is expected.
White BCs.
34,000.
A and C, absolute neutrophil count.
20,000.
Okay, Hiyam, continue.
Yalla.
If he's anemic, definitely. So he will need transfusion twice, at least like 12 hours apart. So we'll give him 20 ml per kg.
Okay, we'll give
yes,
transfusion.
blood transfusion.
What's
for
the volume?
20 ml per kg over 4 hours.
You will give 20 ml per kg.
And yes, and we'll after 12 hours, I'll give another transfusion, or even I can reassess with another CBC.
What you will give with the infusion?
Should you go with
Lasix?
Calcium.
Hiam, if you do that in the exam, you will lose marks. You have to tell everything.
We are learning.
Okay, so you have to. So you give blood transfusion 20 ml per kg, and there is why? Because there is hypotension. Why? Because there is bleeding from the mother. Why? I don't give 10 here. I want to give whole blood. In here, I don't give packed RBC. I will give whole blood. But if packed RBC is okay, and I will give Lasix with it. Okay. So what about the blood test?
Platelet is fine, more than 10, and if there is no bleeding.
No, the platelet is 110.
110. Yeah, above 100 is fair enough if the PTT is normal and there is no bleeding. So we'll consider it only if there is active bleeding.
So you didn't answer my question. How frequent you do the blood test?
In such a case, I would repeat it 12 hours.
12 hours. So you leave the baby alone with 12 hours. Then you come after 12 hours and you do the test.
He will take 4 hours for transfusion at least. I decide to give back the RBCs.
You will not do blood gas?
Blood, no, we're talking CBC only now.
No, I
blood
said
gases
blood
I will do.
I didn't say CBC, Doctora. I told you what is the blood test, frequency of blood tests you will do. So tell me.
This baby is ventilated, and I will do it initially 6 hourly, or maybe
do CBC
even more. If the blood gas is not normal, I will do it more frequently.
6 hours. Okay. What else? Blood test. Tell me the frequency.
If it is stabilized, yes. Blood gas, I will do it routinely at 6 hours unless I change the ventilation parameters or lactate is high. So I need to monitor according to the situation.
I understand this. What else?
Yeah.
You did
bleeding
CBC,
profile or
bleeding profile. You're doing blood gas every 6 hours. What else?
renal function test,
and
renal function.
electrolytes and minerals.
How's the
Sodium,
frequency? I mean, how many times? I've told you, I've asked this question maybe 7 times now. What is the frequency of the blood test?
We repeat after 12 hours.
Yeah.
Which one?
Initial.
CBC, electrolytes, minerals, and liver function test.
So you will do CBC and electrolytes every 12 hours. That's what you're telling me.
For the first 48 hours.
For the first 40 hours, you will do CBC and electrolytes every 12 hours. Is that right? You will do it in this way, and gas every 6 hours. What else?
We did LDH.
I will tell you what I will do, Yaman. I will tell you what I will do.
Yeah.
I will do the answer. Now the answer. I will tell you the typical answer. I will do a blood gas every 6 hours, and if needed for any crisis management. I will do electrolytes every 12 hours. I will do CBC every 24 hours. I will do coagulation every 48 hours. And I will do liver function every 48 hours. That's how I will monitor the baby, and if extra needed. That's how I do the blast test. And then I will ask for troponin and other enzymes to assess the multifunction. I have to see if the liver is functioning or not. And then I will assess. There is very other thing you have to assess. You didn't tell me. So this is the frequency of blood gas. So you did the frequency. What else? You started antibiotics. You did blood culture. You limit your fluid. You control your hemodynamics. You control your CNS. What else? And your cooling.
Urine output and renal function test.
Yeah, you said that. We said that urine function every 12 hours, and you start to calculate the urine output. Okay, what else?
Neurological assessment, clinical neurological assessment, and documentation.
So tell me the neurological assessment. What you will do?
Before that, if the kidney function test start to arrange, we have to stop the gentamicin considering cefotaxime.
That will take long time.
So we need to keep on CFM.
You'll keep CFM. What else?
And monitor heart rate, blood pressure.
No, the CNS. Let's wait. He started cooling. He gave phenobarb. He sedated the baby. You started CMF. What else for the CNS you will do in asphyxiated baby?
Neurological assessment by a specialized.
Yes, you call for a neurologist. You don't do that, Muna?
Yes. Yes, we do.
Yeah.
Do we need to do a CKBD?
Yeah, okay. So what else? We're missing one part, one of vital organs.
Liver.
No, the liver, we said we will do the test.
The gut will start not
anything
feed.
about the
Will not start feed.
You will start feed or not?
Will not start feed at least for
Why?
24 hours.
Why?
Because you expect gut hypoperfusion also.
Yes.
So the risk for neck will be higher.
There is no bloody stool, no abdominal distension, positive bowel sound, and if there is imaging you need to do until you start feeding. So you will not start feeding. I think you covered everything, Dr. Yaman.
Okay.
You guys enjoying it?
We have last 7 minutes.
I have to stop here. I think it's too much. And let's open the floor for questions. Okay. Thank you, Dr. Yaman. أهم شيء ما تزعل.
لا ما حصل مس اندرستود بس لكن مشت الامور.
Questions? Dr. Rula, any question?
There is a comment from one doctor to do brain MRI Q24 hourly. I'm reading the comments.
Oh, wait. That's the dangerous comment.
Yeah.
Yaman, when you will do the MRI and why?
With EEG. She has mentioned cranial ultrasound Q24 hours with EEG.
So Yaman, will you do cranial ultrasound?
Day 5.
You will do on day 5.
Oh, after 7 days.
So you will do a cranial ultrasound on day 5.
Yes.
Yes, no. Yaman, yes, no.
So I said after 1 week I will do the MRI.
So will you do ultrasound or not?
No.
No, Hayam.
We will do at day 5.
Who's speaking? Yamin?
Dr. Ahmed Ali.
So Yamin, will you do or not?
No, I will not do an ultrasound.
Yeah, you will not do. Yamin will not do. Hiyam, will you do ultrasound or not? Dr. Hiyam.
I think yeah maybe.
يلا جاي تعال.
Okay, well, Muna, Dr. Muna.
If I will do ultrasound only to see if there is IVH, but it will not help me in anything else.
So you will do or not in this baby?
I will do brain ultrasound.
You will do a brain ultrasound.
Yes, but not MRI. At day 1.
You will do ultrasound on day 1. Okay. Muna, you will do or not?
Yes, I will do.
Okay. Mahmoud, you will do or not? When you will do it, Muna?
I can do it after 24 hours.
Okay. Well, the logic question here is why, but I will answer that.
Actually, I just wanna do it because the baby has low hemoglobin, and if he continue to have low hemoglobin, I just wanna make sure he doesn't have IVF.
Yeah, where Mahmoud? Mahmoud, will you do or not?
Really, I don't know. Like.
Okay, so I will not do ultrasound, but I would agree with Mona because the hemoglobin is low. So if I give blood transfusion and the hemoglobin is improving, then probably the bleeding is because of the mother. I will not do ultrasound. But if the hemoglobin I give and the hemoglobin is improving, is worsening or decreasing, I will do one ultrasound. Otherwise, the ultrasound is useless. Okay, and there is no benefit. It will have edema and will be split like ventricles, and there will be increased echogenicity due to hypoxia. No, so the question is, will you do MRI or not?
Early MRI and to compare with later, yes.
How early? What age you will do?
Acutely, I think the picture will not be accurate due to brain edema, and it will not be that informative.
So if there is edema,
so
MRI
CT scan at 2 weeks.
MRI at day 3 and repeat at 2 weeks.
2 weeks.
MRI, the
3 to 5 days.
You will do and when and why? Muna, Hiyam.
I think 2 weeks will be fair enough, but early I don't think it will be that informative.
You will do it at 2 weeks. Oh, okay. So Yamin, let's ask Rola. Rola, can we ask you ولا أنتِ لا ما نسألك؟
عادي دكتور.
Yeah, when you will do it?
3 days, and I will repeat at 2 weeks. I will do 2 MRI at 3 days and at 2 weeks.
Okay, why? Probably you are the best answer till now, but why?
Because it will show me the changes even at earliest possible regarding the
yeah. So you will not do it in the first 4 days. You have to do it somewhere between 5 and 7 days. Reason because the baby is on hypothermia. And there is evidence right now that if you do MRI in hypothermic babies, 50% will be normal despite there is abnormality. So cooling will limit the finding of the MRI. The main thing is we do water diffusion, water restriction. Is there is restriction or not in the watershed area, in the hippocampus, in the basal ganglia and the thalamus, because these are the most vulnerable area. And you will do it between 5 and 7 days. If you do it after 7 days, you will lose the opportunity to diagnose anything. It will not be a prognostic. If you do it on day 14, you will see the gross malformations, the gross abnormality, the structural abnormality, not the metabolic or cellular abnormality. So the best timing in a cooling patient is between 5 and 7 days. And I can send you the evidence why we're doing it. So if you do it earlier, you will limit the finding. If you do it later, you will lose that window to find the cellular abnormality.
And after we finish cooling, after we rewarm the baby, we do MRI. That is our first, but then we
Yes.
repeat it at the age of 14 days.
So same of my answer.
Yes.
Yeah, same of my, because you don't want.
Is there any? Hello.
Yeah, go ahead.
Is there any rule for CT scan instead of MRI?
No. No. It will tell you, it's like, it will tell you like the ultrasound. It will tell you the gross abnormalities. But what you are looking is water diffusion or water restriction. Is there a restriction or not? You're looking to the, because if there is a gross abnormality, ultrasound will pick it, CT scan will pick it. So you're looking on the cellular level. The MRI will pick it. The details, but the MRI cooling will not detect. So if you're cooling, you might not see it. You might limit the finding of MRI when you're cooling. So first you have to rewarm as-Rula. And most people also, baby is more stable hemodynamically. I don't know if you have like MRI compatible ventilator or not. The transport, where is the in MRI, how long you will have to transport the baby, all these factors in the. So if I have very good facility, I will do it day 5, but don't delay it after day 7 because these abnormalities will disappear.
And there is a request from Dr. Saad Saleh. He is asking for the algorithm for management of neonates who needs cooling. I don't know if we can obey his request.
Yeah, I have it. I have a document, if you remember how to, the standard order and what to do and what's the, and I have like a complete guidelines on how to do it. I think I made one for you, Arula, right?
I know, بس في دكتور بيسأل عنها, دكتور سعد صالح.
Yeah, we can forward it to him. We have the guidelines to guidelines on how to cool and guidelines how to treat hypothermia, asphyxia, and we also have a guide, the standard orders that you will give. So all these are available. Any more questions? Or should we stop here? 2 hours now.
Too many thanks on the page. Too many people are thanking you for the discussion.
Regarding, hello?
Yes, go ahead.
Regarding giving the normal saline during resuscitation, because it is birth asphyxia, is there, they said you have to check blood pressure before giving normal saline. If it is normal, no need to give. If it is hypotension, we will give normal saline. Is it, do you agree?
We didn't give the normal saline for asphyxia.
Yeah.
We gave the normal saline
no, during
neonatal bleeding.
Resuscitation. During resuscitation.
Yeah, but there is a bleeding.
Oh, no need to check blood. No need to check blood pressure before.
It depends on the situation. Are you talking about asphyxia or bleeding?
Asphyxia due to bleeding.
Asphyxia, you don't need to give normal saline.
No need to give blood normal.
No,
yes.
but we gave the blood because the mom was bleeding.
Okay.
Yeah, that's the reason why we prepared, not because of asphyxia. Asphyxia, you need to limit actually that, because you will have the antidiuretic hormones, you will have hyponatremia, you will have syndrome of inappropriate, you need to restrict the fluid. You don't need to give normal saline. But we gave the normal saline because the mom was bleeding. And then when we did the CBC, the hemoglobin was actually 4.
Oh, yes, I get it. Thank you.
Yeah, thank you. Any more questions?
Yes, there is a question from Dr. Hindel Shinawi. Is erythropoietin given routinely to all HIE cases? Erythropoietin, I think she's
there is evidence that there are many evidence, we can list them. There is magnesium sulfate. There is study going on, we call it COL-MEC. They are going now and people are recruiting. And there is also people give erythropoietin and people are giving melatonin and cooling. The evidence right now is the hypothermia, active hypothermia, therapeutic hypothermia. There is evidence, but conflicting. So people are giving erythropoietin and they say it can protect. But it is standard of practice? It's not, because the evidence is conflicting. But if you want to give it, yeah, you can give it. But the standard of practice is cooling, hemodynamics, protecting the baby, correcting the acidosis, correcting the hypoglycemia, correcting the calcium level, and sedation, controlling the seizures, support in addition to cooling. These are only the evidence. But people are trying many other things. There is melatonin. If you Google, there is also people give melatonin, and they say it works like some centers like, and erythropoietin. And there are many other medications that unproven, these conflicting data. So erythropoietin is being mentioned, but that's not standard of practice.
I think Dr. Hadi was trying to say something. I'm not sure if he's still on.
Okay, thank you, Roland. Dr. Yahya, I have for the indication of cooling, is there is an indication in mild hypoxia?
Yeah, when the cooling started, is only not in mild. But now people are because now it's more available and easy to afford and become cheaper and cheaper. And now people are trying it in mild one. So, but we have a criteria, and you need to follow the criteria, and you assess the criteria at birth, at 1 hour, at 3 hours, and 5 hours. And these criteria, the gestational age more than 35, and I can tell you why 35. And if you have Apgar score less than 7 at age of 10 minutes, and if you need PPV or pressure support or support more than 10 minutes, and if you core pH less than 7.1 and bicarb less than 16 and base less than 12 and base excess more than 16, and or you have an abnormal movement, and there's other criteria, which is the reflexes, the heart rate, whether fixed or not, the level of consciousness. You can assess these every at birth, at 1 hour, at 3 hours, and 5 hours. And if it fit the criteria, then you start cooling. Now, if you have like 3-4 cooling machine and you want to try cooling with, and it's not expensive, the patient can offer it, and the insurance company will pay for it, then you can try. There is not, because the complications are very minimal, which is subcutaneous fat necrosis, some cooling, and the baby is unhappy. You can try it, but again, because people don't do it because the expense, and because it was not available. So each unit will have only one. So you cannot put it on a mild and then you get severe and you don't have. So if you have 3-4 machines, you can try. And if the patient can afford it, because it's very expensive. And if because most of the companies, insurance companies, now when I call, insurance company will ask me why and what's the criteria. And they review it. If it's not within the criteria, they will not pay for it.
Okay, thank you. I have a raised hand from Dr. Saad Saleh. Dr. Saad Saleh, please.
No, Assalamu alaikum. Thank you, Dr. Yahya. What is the duration of cooling for this asphyxia child? And is there any criteria that we can stop cooling? Thank you.
Yes, the cooling is 72 hours. The standard now 72 hours, and the rewarming is between 6 to 8 hours after 72 hours of cooling. And yes, there is criteria to stop cooling. If there is, you cannot control the blood pressure, the baby is hemodynamically unstable, you have active bleeding, or you have severe infection, very obvious infection somewhere else, or you need a surgery. So all this are an excuse. Any hemodynamic instability, congenital heart disease, you need a surgery, for example, for the bowel. You have like congenital diaphragmatic hernia, for example, and you need interference. Hypotension that uncontrolled, all type of shocks, especially the sepsis cause of shock. All these are excuses to stop cooling.
Okay, thank you.
Most welcome.
I have a question.
Yeah.
If you will challenge your decision that at the beginning you thought this baby is eligible for cooling, and after you initiate the cooling, you find that the baby is active enough to stop cooling.
No, you should not stop cooling. Once you start, you should not go back.
Okay.
So once you decide cooling, you go ahead. Because if it's mild, it will get some benefit, as Dr. Hadi was pointing out.
Tamam.
So if you decide cooling, you can say start, but you stop cooling if there is contraindication, because you will be legally responsible. If you stop the cooling and like at 24 months, you do Bailey assessment and the baby is neurologically impaired, you will be in trouble. So once you initiate cooling, you have to continue. So you can only stop the passive cooling.
Yeah, the indication to stop cooling once we initiate it is if I have side effects or deterioration of the baby condition, like clotting.
Contraindication to cooling, which is unresponsive hypertension, very persistent unresponsive hypotension. For example, congenital heart disease. For example, you need to do surgery. For example, you have shock. For example, you have active bleeding you cannot control.
Okay. Okay.
Because the side effect of cooling are mild, is subcutaneous fat necrosis, maybe a little bit of shivering, maybe unhappiness of the baby, delay feeding, maybe some hypercalcemia, some electrolyte disturbance, nothing more than that. It can also change the bleeding profile. You know that when we check the blood gas, the machine will assume the temperature is 37. So what you do is you have to correct the temperature to the temperature of, so if the core temperature of the baby is 34.5, you have to correct the machine, the gas machine to that, or you do a correction. There is a formula how to do correction with each temperature. So this is another complication, but no serious complication. The only problem when you cool mild is the cost and availability. Okay. So if you can, people can do. That's why the selection criteria is because of that.
Okay.
If you have severe IVX, such as intracranial bleeding,
contraindication,
then maybe you don't need to cool that. If you have a gross abnormality, then you don't need to cool.
No. Okay, I think it is now 8:11. We have already passed the time assigned for today's session. Thanks a lot, Doctor. Thanks loads for this.
Thank you very much. If you guys like this, we can repeat it sometime.
Thanks a lot, Dr. Yahya. It's very nice. Thanks a lot, Doctor. Very challenging.
The next session,
Thank you for your time.
Antenatal assessment. Okay.
Discussion.
Okay. It will be discussion, something like that, but we will get more information. But I think people like cases. They enjoy the cases.
And for those who please missed the session, the live session, because they have faced some difficulties with the voice, you please can enjoy watching it again on the YouTube, the channel. Doctor, you have already sent it on the...
Yes. They can watch it over there. Yes, definitely.
Thank you very much.
Thank you very much, everybody. Enjoy the rest of your night. Sleep well. Have a sweet dream, and we'll see you next time. Assalamu alaikum.
Thank you.
Alaikum assalam.